we should be able to see the agenda there. So I apologize. We are having some IT issues this morning. So thank you for bearing with us. We have some people in the room with us today. So we're using computers and trying to blare our audio. So thank you for your patience. We are going to go ahead and call to order officially at 10:36. Just a reminder that this is a public meeting and is being recorded. Anything that is shared via the chat or on video is part of that recording. It does become permanent and part of the YouTube video recording of today's meeting. So just to keep that in mind, if you are not speaking, if you could please keep yourself on mute. If you're attending by telephone only, please press *6 to unmute yourself. Shelley and Julie are going to monitor the chat box for questions. And for everyone's benefit, please identify yourself by name before making a motion or remarks. So that way we can identify who is participating. Again, big thank you. I know this virtual hybrid format is sometimes somewhat problematic. So we do appreciate everyone being so flexible with us. Shelley, are you ready for roll call? Oh, Julia is going to do roll call today. Thank you, Julia.
I apologize in advance if any names are said incorrectly, but we'll get started. Alberto Gutier, Bob Ramsey, Brian Smith,
Present.
Chris Salvino, Dale Woolridge,
Here, thank you.
Daniel Spates,
Dan Spade is here.
Deborah Garambe, present. Thank you. Michael Castro Marin, Gail Bradley,
Present.
Garth Gamer,
Present.
Glenn Kaspersik,
Present.
Heather Miller, Howard Reed, Eve Gudzenker, thank you. James Hayden,
Present.
Michelle Preston,
Present by phone.
Mike Duran, Neil Williamson,
Present.
Rebecca Haro,
Present by phone.
Rodney Reed, Roy Riles,
Present.
Sarah Parati,
Present.
Sherry Brands,
Present.
Sharon McDonough,
Sharon McDonough is present.
thank you. Stevie Merrill, Todd Jaramillo,
Present.
Vince Martinez,
Present.
and Vivian Gillett. We have quorum.
Excellent. Thank you very much, everyone. Next up is the attendance report. This is in your meeting packet as well. Just a reminder, if you do miss 2 or more consecutive meetings, the Bureau will contact you to determine if you'd like to participate and continue to be on the committee. Next, we have 3 vacancies, 2 for public members and 1 for hospital administrator for a county population greater than 500,000. If you are interested in applying, you can go to the Governor's Boards and Commission and apply at that website. We would like to welcome 3 new members today, Dr. Godzenker, who's here present with us today, Dr. Brand, and Dr. Merrill. So we're very excited to start filling our ranks back up again. So welcome to the committee. We have also several recently reappointed members, including Jim Hayden, Vivian Gillett, Michelle Preston, Sarah Parati, Rod Reed, Heather Miller, Howard Reed, and Chris Salvino. So welcome back to the committee, everyone. Next, if we can
Thank
just
you.
click on the tab for naloxone leave behind. I know I have mentioned this at the previous committees, but I wanted to just reiterate this as well. One of the trends we have noticed in Arizona as well as nationally has been the increase in opioid cases, along with opioid overdoses and deaths. And so we've tried to help facilitate the naloxone leave behind program and make it as simple as possible. With this, we have created a new tab on our website. So on the homepage at the bottom, there's a square you can click on for naloxone. That will then take you to this page, which is specific for EMS. We have a copy of the standing order. So if you are a BLS agency and do not have medical direction, needed naloxone, there's a standing order you can utilize. We have a letter regarding this naloxone leave behind program, a sample policy and guidance, a guideline, as well as a training PowerPoint. A big thank you to the Education Committee. They put together an excellent training PowerPoint that I think could really be implemented in any jurisdiction in Arizona. There's also a template educational pamphlet that can be handed out with the naloxone. This can be altered to make it specific to your jurisdiction to import resources for patients in your geographic area. And lastly, we do have a link to the Office of Injury Prevention, and this is where you can order free naloxone for your agency if you need some. So if you have any questions regarding implementation of naloxone leave behind, please feel free to email me or Shelley, and she can forward that to me as well. But we just want to make sure we continue to advertise that across the state. Any questions before I move on? All right, thank you. Next is the proposed 2022 meeting schedule. If you see any conflicts, please let us know as soon as possible. We unfortunately had a conflict for today with a religious holiday that was not identified previously. So if you do notice any conflicts for 2022, please let us know and we will make any adjustments necessary. And lastly, for my report, the National Association of State EMS Officials, or NASEMSO, has published the draft version 3 model EMS clinical guidelines. They are asking for public comment. That survey is attached here. We have a link in the electronic agenda. We utilize the draft or the model clinical guidelines to do both the first and second version of our T3Gs, or treatment, triage, and transport guidelines. And so we really would like anyone in the state who has public comment, please feel free to participate in that. Are there any questions for me before I hand this over to Chief Garcia? All right, thank you.
All right, good morning. This is Rachel Garcia with the Bureau of EMS and Trauma System. We continue to navigate through this virtual environment and we'll be playing with the audio as we go along, so please bear with us. So I'd like to start out by acknowledging that September is Suicide Prevention Month, and with the 20-year anniversary of 9/11, we also feel it's a time for reflection, and we'd like to stop and thank our first responders and healthcare workers that continue to serve on the front lines during this time. The department has recently received grant funding to be able to implement a Start a Conversation campaign, and we have some resources that are now highlighted on our website. They can be found at azDHS.gov/startaconversation. There are resources available for both employers and providers, highlighting the importance of staying connected during this time. The department's also received a grant to be able to fund a full-time position for the next 2 years that will be focused on EMS resiliency during the pandemic recovery. We look forward to having this position work with the EMS Council as well as the Education Committee to be able to develop any resources that may be necessary or needed as we look forward at the next 24 months. At the national level, we continue to hear there are studies tracking increases in violence against providers and EMS fatigue at this point in time. And so we commit to you that we'll continue to update our EMS resiliency website, and we will accept any feedback that any of the council members have that may help us to pull together some more resources for the community at this time frame. I have some federal and state COVID-19 updates to share. Hospital capacity remains a major concern of ours at this time. As you all know, we're competing against other states with critical staffing shortages nationwide. The state level emergency declaration remains intact, as does the surge line that continues to facilitate transfers for COVID-19 patients only. Arizona has received a federal strike team that will support the northwestern part of the state with some of the hospital staffing shortages they have faced there. And the Arizona Surge Line has also announced their staffing initiative that is backed by $60 million of grant funding, or I'm sorry, state funding, to be able to provide RNs for ICU and med-surg staffing support in hospital settings. The Surge Line has been able to procure over 250 nurses to date. Those 250 RNs are scheduled to start by the end of the month. The Surge Line's been able to serve, I believe, all of the hospitals that have applied to the program to date. And so we're very fortunate that that's a resource that's going to be available to hospitals in the coming weeks. For EMS Council, we have an annual report that will be circulated soon. If it has not been already, we look forward to reviewing that with the council and receiving additional feedback on some of the trends we've seen during 2020 with the onset of the pandemic. There are some concerning trends that Vatzel will highlight, I believe, as she shows some opioid and out-of-hospital cardiac arrest data that is more recent. You'll also see some of those trends reflected in the EMS Annual Report that continue to reiterate to us the importance of, as Gail said, promoting the naloxone leave behind program, as well as the Cardiac Receiving Center program. We'll expect to follow up soon with the council with the Pandemic Recovery and Response Report to begin to dig more into some of the trends that we're seeing and perhaps provide some recommendations for improving patient outcomes as we go along. One of the trends we're keeping an eye on is EMS workforce. We want to make sure we have a good understanding of how many folks are going through classes right now. We do know that class sizes are down, and we expect that some of our workforce numbers may dip a little bit in the coming year. So we'll keep an eye on the EMS workforce pipeline. And again, we're open to any suggestions the council can provide on how we can recruit, train, and retain EMS workforce in this state. For scope of practice and rule updates, you are all aware that we have had an updated EMCT scope of practice effective August 9th. On the ambulance rulemaking process, the ground ambulance rulemaking process is still in the informal stage. We continue to have informal meetings with the work group. There is a new August draft posted, and there is a survey open on our website, open until September 26th for comment. The air ambulance process is now entering the formal stage. For anybody interested in providing formal feedback during this time period, we encourage you to check out the department's website or the register to be able to get information about how to submit any written comments or participate in an oral proceeding before the end of the month. I think that covers the majority of the updates I have to share. The last thing I will note is that there is a survey that we would like the EMS Council to take. There should be a link in the agenda. We are seeking input for a critical care definition that will be included in the ground ambulance draft rules. This definition, we hope to expand to be able to include any certification or training requirements for critical care staffing and critical care services. This is a definition that can continue to be expanded on as we think about additional critical care certification and education in other parts of our rules. At this point, Julia, may I turn it over to you to introduce a couple of our new staff who have started this week?
Yes, thank you, Rachel. We are excited to welcome Marissa Salgado, our new Based Hospital Compliance Administrator. I believe she's on the line right now. So welcome, Marissa. And Adam Rodriguez, the EMS for Children Coordinator, to the team. We look forward to working with both Marissa and Adam in these new roles moving forward.
Thank you, Julia. Next, I would like to turn it over to Travis Connors, who's also a newer member to the Bureau. He is new to us, I think, since our last meeting, and he's going to talk about the new process for applying for a pilot project. Travis, I'll hand it over to you. Thank you.
Thanks, Dr. Bradley. Good afternoon, everybody. So the purpose of the pilot study application was to allow the department to authorize a testing, evaluation of medical treatment, procedure, technique, practice, medication, or piece of equipment for possible use by an EMCT or an emergency medical service provider pursuant to AAC R9-25503, as well as ARS 362205. Now, the goal was to develop an application that allows entities or individuals to submit a pilot study proposal to the Bureau of EMS and Trauma for review in order to be considered for approval. Additionally, as part of the review process, the Bureau will utilize the Medical Direction Commission, MDC, as an advisory body to provide guidance to the director in making a decision. Within 180 days after receiving the proposal, the department director shall send written notification of approval or denial of the proposed pilot study to the individual or entity making the request. If approved, the individual or entity must evaluate the pilot study and provide a written report to the department director. This application now allows entities or individuals to formally submit a standardized and uniform pilot study proposal application to the Bureau in order for us to review and consider for approval. This will be going live fairly shortly. Furthermore, the Bureau has created a pilot study application checklist that will summarize the type of information and documentation required for an entity or individual to submit a valid pilot study application for consideration to be approved. This checklist will be available to the public on our EMS and trauma webpage. We highly recommend entities or individuals who wish to submit a pilot study application to review the checklist prior to submitting the application in order to ensure all required documentation and information is present to submit a valid application. Now, the location of the pilot study application as well as the checklist will be on our homepage as stated previously. It'll be under the EMS, MDC, and STAB tile. From there, you'll click on the Medical Direction Commission MDC tab. Underneath the online membership application for MDC, so there's bulleted information here. It'll live right underneath the online membership application for MDC. For all further inquiries or to receive more information related to the pilot study application, please email emspilotprojects@azdhs.gov. Again, that is all one word, emspilotprojects@azdhs.gov. Thank you.
Thank you, Travis. Are there any questions for Travis or for the Bureau regarding that process? All right, thank you. Next, I'm going to turn it over to Voxel to present some data on out-of-hospital cardiac arrest and opioid.
Good morning, everyone. Okay. So as you can see in the cardiac arrest, the pink color, the last bar is 2021 data, and we have July and August data available for the 2021 year. And there is slight increase what we observed in cardiac arrest cases in July, and then quite a bit increase in the month of August. We can go to the next page. The deaths have stayed at around 66-64% side, both last year and this year, for the month of August. Go to the opioid. Transported, again, we are still observing the same trend that in the 2018 and 19, more patients were transferred to the hospital, whereas in 2020 and 21, we are still not seeing the less patients are getting transported to the hospital. So the trend still continues. And then the opioid data, there is a slight, I think that this increase, a bit increase in the opioid cases in the month of August. But we are in the range of kind of 1,000 cases a month, for opioid overdose cases. And the mortality, I don't think so. We saw. Can we go to the mortality page? Yes. Okay. So the number of mortality is, this monthly gets very fluctuated because of the such a low volume of the data. So we are right now just currently observing the volume to see if, the long-term effects. I don't see right now, even though it shows a lot decrease, compared to the last month, but keep in mind that, we have such a small sample size. That's about it.
Thank you, Vatsal. So certainly with the trends we've seen, both with out-of-hospital cardiac arrest and opioid-related incidents, we definitely want to put some additional emphasis on naloxone leave behind program for EMS statewide. And really in 2022, we look to kind of reinvigorate some of our share program and look at what we can implement to help increase and improve outcomes from out-of-hospital cardiac arrest. Any questions regarding any of the Bureau report? All right, thank you. Next, I will turn it over to Rebecca for our TEPI report.
Thank you, Dr. Bradley. Good morning, EMS council members. One key thing to note, Julia Vinton is now in charge of our Safe Hearts in Arizona registry. So if you are continuing to submit situations with AEDs, AED use, all that type of thing, as well as any cardiac arrest data, Julie is in charge of that now. One other thing of interest, Ann Vosbrink shared that our EPCR vendors are currently testing with Nemesis. The tentative date to open up AZ peers to allow Nemesis 3.5 submissions is right now to be the end of this year, 2021. The Nemesis deadline to shut off version 3.4 is December 31st of 2022. Let's see, trauma center designation during ACS COVID-19 extensions. They basically postponed site surveys. And again, even inspections, COVID interfered with a lot of this process. Hopefully, as things start to improve within our state and our county, we'll be able to resume some of those categorizations. And then Chief Garcia discussed ideas with us to incorporate for our annual report generation to help us better understand raw counts, percentages, et cetera, and to better understand the data review with regard to changes in healthcare and impacts to the workforce that occurred to accommodate the pandemic. And Dr. Gators actually suggested that we use a COVID overlay on each graph to better display the impacts. Additional impacts on the data do include increased population counts, and now we welcome Phoenix Fire and their data that they're submitting. The next TEPI meeting will be November 18th at 9 o'clock, location to be announced, and that's the end of my report. Are there any questions? Hearing none, thank you, Dr. Bradley.
Thank you, Rebecca. Next, I'd like to turn over to Brian Smith for both the education and PMD reports. Brian?
Thank you, Dr. Bradley. Our last meeting on July 15th for Education Committee, we had been developing a post-test for the pediatric tracheostomy management for EMS. That was approved and has been posted on the Bureau's education website. As Dr. Bradley noted, we did approve the naloxone leave behind training. That is posted also. Another topic of education that we had decided needed some updating was the LVAD training. That was approved. It's now EMS care of the patient with mechanical circulatory support, and it includes LVAD and now total artificial hearts, and that has been posted on the website also. Our standing items to review posted training modules did not have any recommendations for any more updating at this time. Dr. Amber Rice presented information on the Arizona for CPR and ACLS training that's specific for pre-hospital providers called Applied Resuscitation and Education and Specialized Training, or ARST. There were discussion items about pediatric training and education in Arizona. The amount of hours that's currently required for recertification and training gaps, including pediatric trauma triage and assessment training. And there were a number of ideas that were brought up, and that will be a topic that will be continuing on. That's the completion of my report for Education Committee. Protocols, Medications, and Devices also met on July 15th. There was a request to develop drug profiles for Table 2 agents eligible for administration during a hazardous material incident. There was approval to have a work group formed for that. There was one volunteer at the time, so if anybody is interested in assisting and participating for that, please contact the Bureau. There was a request to add tranexamic acid to Table 1, the EMCT drug box list. And that motion did go forward and will be going to Medical Direction Commission this afternoon. Also, a draft drug profile for TXA was submitted. There were some amendments to that, and that will be moving forward to Medical Direction Commission also, as it was approved with the suggested amendments. As has been noted, the NASEMSO Model EMS Guidelines version 3 is available for comment now, and we will continue looking at when that is done. We know we will need to have a work group formed to look at and compare with the Arizona treatment guidelines and what we might need to do to implement that into our current and revise our guidelines. There was also discussion and approval to add a limited use Table 1, and it would cover wildland type teams, bicycles, segways, UTV teams, and that motion was approved and will be moving forward to Medical Direction Commission this afternoon also, and that's the completion of my report. Thank you.
Thank you, Brian. Next, for the Regional Council report, we will start with Roy for Ames report.
Thank you, Dr. Bradley. The report was distributed in the most recent email from Shelley, so I won't belabor a lot of it, just hit a few highlights. We've had 2 board meetings on June 16 and August 18. Our next board meeting is scheduled to occur via Zoom still on October 20. The EMS Odyssey Conference was very successful on June 9th, which is really kind of our first big conference of that nature on a Zoom platform. It worked out very well. We had 240 participants, and of the participants, 158 requested and were awarded CE certificates. And you can see the breakdown in the report in terms of certification levels. And lastly, we're just kind of finishing up our fiscal year, and we'll be completing very shortly our annual financial review by external consultants, or external auditing group. So that's about it.
Thank you, Roy. Next up, Sarah for SAM's report.
Thank you, Dr. Bradley. When last I reported, I commented on the direction Dr. Gaither gave us to establish a special project group with respect to communications between hospital and EMS, especially in light of COVID, which made it more acute that we establish better communications to ensure that, when we're dropping patients off at the hospital, that good communications have happened and that those communications are agreeable to both. We've made extensive progress on this already and have already sent out draft documents, which are circulating in the region for comment, which establish baseline communications parameters, again, of which both hospital and EMS partners have agreed. So this was able to be facilitated between both groups in a support process through the region, and that has been incredibly helpful. We'll continue to move forward on that, and we'll update this group about the final results of the draft comments and what is ultimately presented to the council moving forward. As for ongoing business, we have managed to remain on point and on time throughout the 2021 year for our established work groups and meetings through using the Zoom and virtual format. I think that says a lot about the commitment of our EMS and hospital partners in the region. It has required a lot of extra work to do it that way, but we haven't missed a meeting. And so I commend everyone in our region for continuing to fight the good fight. As for 2022, we will remain in a virtual format until otherwise noted. We will have our 2022 calendar out for the October meeting. Another important point is that when we met yesterday in regional trauma and in medical directors, we were able to move forward an extensive number of additional standing orders, which were in agreement by the consensus of the medical directors group. And then with respect to regional trauma, we have been able to integrate our now second level 1 trauma facility into the regional trauma group planning and protocols. So that has been also successful. That's the end of my report, unless anyone has questions. Thank you.
Thank you, Sarah. Next, Vince for a names report.
Good morning. I've submitted the names report. I'm not going to go over all the details, just the highlights. I did notice an error. Apologies. We're moving forward with the 2022 NAMES Annual Pediatric Symposium, and the event is scheduled for February 28th and March 1st, not the 9th. My error, sorry. And, you know, with the unknown progress of COVID, we don't know if this is going to be a virtual event. We would hope that it would be in person. But as we move forward and see what's happening, we're just preparing for both contingencies and more to follow on that. We met as a NAMES Council on August 13th via virtual meeting. And some of the highlights, Flagstaff Medical Center Trauma Services is providing Stop the Bleed training for NAMES agencies. It's free. It's part of a grant that we received over a year ago. And part of this is we'll give you $700 worth of Stop the Bleed supplies. So if you're interested in this, please contact Sean Bowker for details. Also, Flagstaff Medical Center Trauma Services is a point of distribution for some cases of gloves and cases of Tyvek suits for agencies that need PPE. So if you do need some of those supplies, please reach out to Sean Bowker. And our next meeting will be November 5th, 2021. If you have any questions, please let me know.
Thank you, Vince. Next up, Rod for Western Region report. Rod, if you are on the line, we are ready for your report. If you're able to give it, you may be on mute.
Okay, can you hear me now?
We sure can. Thank you.
Okay, great. Sorry about that. I unmuted my phone, but apparently I had to do the *6 as well. We are at our July meeting. It was a in-person and virtual meeting both. We approved our budget and the provider assistance process for this year. We renewed our protocol app. If you've never seen that, that's a really pretty neat deal. And our next meeting is November 10th. We'll be in Yuma. We'll be in-person and virtual meeting. And that's all I have.
Thank you, Rod. Next, I think Julia is going to be giving the PACES report today. Julia?
At the last PACES meeting in July, PACES welcomed one new member, Dr. Joshua Zeidler. Members approved a set of post-test questions to accompany the tracheostomy training that was developed and approved earlier in the year. These are now posted on the Bureau's webpage along with the training PowerPoint slides. PACES also approved the development of 2 work groups, naloxone for pediatric patients and behavioral health. These work groups are ongoing, and we hope to have items produced to present at the next PACES meeting in November. Lastly, EMS for Children wrapped up data collection through the National Pediatric Readiness Assessment at the end of August, and we thank you to those who participated. We look forward to sharing the information that was collected through that in the near future.
Thank you, Julia. All right, next for discussion and action items, can I please get a motion to discuss, amend, and approve the meeting minutes? And again, please say your name when you make the motion.
So
Thank
moved,
you.
Brian.
All right, I've got a first and a second from Brian and Howard. Thank you. We'll take a minute to scroll through the meeting minutes here, and if there's any amendments, please speak up. All right, any opportunity for amendments? For ease of voting with the virtual format, anyone opposed to the meeting minutes as displayed, please say nay. Hearing none, any abstentions? Hearing none, all those in favor, please say aye.
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 Hi.
Thank you very much. Meeting minutes are approved. Next, I am going to hand it off to Ann to talk about the conversion for Nemesis 3.5 timeline. Ann, are you available?
Yes, I'm here. And just going to present my screen if that's okay. Can everyone see this graphic?
Yes, we can see it, Ann.
Okay, great. Before I start talking about it, I want to make sure you guys can actually see it. So we have this timeline available on our public-facing website. And so Nemesis is going to a new version, which happens every once in a while. So they're going to switch from our current version, which is 3.4, to the next version, which is 3.5. The current status is still vendors are entering testing as they're available and as they're ready and going through the compliance process with Nemesis. And as far as state plans, we are hoping still to start accepting version 3.5 to the new version by the end of 2021. This is the tentative target. It's going to be based obviously on software availability and readiness for us to get our system up and running, set up and tested. But our intention is to have 3.4 and 3.5 version submissions overlap in Arizona, so that allows for a transition period for EMS agencies. As Rebecca mentioned earlier, Nemesis is only going to accept 3.5 data as of January 1st, 2023. So any incidents that occur after December 31st, 2022 will need to be in the new updated version. So that basically gives us the year of 2022 to transition all the EMS agencies who are submitting data over to the new version. I personally have a target date for all of the transition to be completed by November 2022, so that we avoid any of the last minute issues if maybe it takes a little longer to set up a system or to troubleshoot and export. Also, we get into the holidays and people taking time off and hopefully not a bad flu season, but everything else. So I think it'd be good if we could plan in our minds on having everybody transition by November 2022, and that's on this helpful infographic. If you're interested in any of the highlights that are involved in this data change, the EMS Registered Users Group, so EMSRUG meeting minutes from April are posted on the public website on the Easy Peers page, and it goes through some of the highlights or changes that might be helpful. And of course, I'm happy to talk with anyone who has questions too. And then just, I would say, watch our website, our public-facing website for updates, changes, and when we have some version 3.5 resources available for use, we'll post those there also. And that's it.
Thank you,
Anybody have any
Anne.
questions?
Yes. Are there any questions for Anne? I know this is a big change coming up. We try not to make many changes with the data set, but this is one that has to be made with Nemesis. So if there's any questions, please speak up now or feel free to contact Anne. She's a wealth of resource and can help you and your agency with the transition. All right. Next, I just wanted to briefly mention the substantive policy statement on EMCTs practicing in the hospital setting. If you can click that link, please, Shelley. This was recently updated, as one of the things that we recognized was that the previous version had the old drug table names included, the table 5.1. So it was updated for that purpose. This is a joint substantive policy statement between the Bureau of EMS as well as licensing. So we wanted to make sure that all EMS providers as well as hospitals were really aware of this. Again, this has been in place. The vast majority of this is unchanged from prior. Really, we updated the drug tables, but we wanted to make sure that this was really widely publicized. I think this was something that's a little bit buried on our website, and not many people were aware that this existed. And it really goes into specifics about what is required if an EMT or paramedic is working in the hospital setting. One of the things that we have heard from a number of hospital systems in the last few months is that with the nursing shortage in place, they really want to look into how they can expand their workforce and look in utilizing EMS providers, so EMTs and paramedics, to help augment care provided in the hospital setting. Many other states have utilized EMS providers to a lot greater extent in the hospitals than we have in Arizona. And so we really want to make resources as readily available for hospitals and EMS providers. So if there's any questions about this, this is a link in the agenda. Otherwise, it is on the website, but it is a little bit buried. So we wanted to make sure that this was available for everyone's review.
Gail, may I ask a question?
Yes, Rebecca, go ahead.
So I have an EMCT who works in an ER in a hospital. I'm not sure what her position title is, but she was trained to do blood draws, start IVs, etc. And she's a very gifted skill provider with IV sticks. In fact, a lot of the nurses and even our medical director will say if they've got a really challenging IV start, they will grab her to do it. Now, based on the fact that the hospital hired her to fill that role and they trained her, that doesn't interfere with her being an EMT when she works for us, correct? She doesn't step outside of her scope of practice at all as an EMT on our units, but she has an entirely different position in the hospital where she is not working in her EMT skill set.
So yes, that definitely comes up, Rebecca, in terms of if an EMT is working in the hospital setting and doing something that would be considered a STR, they would need to have medical direction to do that. The hospital would need to provide that. Certainly the agency, so you could elect if you wanted to allow her to utilize that STR with your medical direction in the pre-hospital setting as well. So that is, I see a head shaking no. It would be an opportunity if you wanted to.
Absolutely. Thank you for that clarification.
Yes, thank you, Rebecca. Any further questions? All right, next we are going to bring up the 2020 EMS Annual Report, and I believe Vatsal will go through some of this for us. And this is a draft form. We are still going to be making some adjustments as we review some of the final data. So you will see draft across the entire document. Vatsal, you are on mute if you are trying to talk.
Dr. Bradley, I can go ahead and present the report.
That would be wonderful, Sri.
Yeah.
Go ahead. Thank you.
Hi everyone. So this one is a 2020 EMS Annual Report. So this is pretty much all the introduction and report from the report to the director and everything. But yeah, we can go to the snapshot.
Do you have a page number for the snapshot, Sri?
Yes, I haven't opened it on.
Oh, there it is.
Yeah,
Thank
this
you.
one. Yeah, it's page 11. Okay. So maybe we can just zoom out a little bit so that we can see the whole. Okay. So anyway, so this one is like basically a snapshot. It will give you like the pages in the other. We'll talk more in detail, but this kind of gives you an overview of what the 2020 data is showing to us. So you can see like there is a 166 agencies that have submitted data to us. It's an increase from the last year, and how many average number of EMS incidents per day. And how many were 911?
Last एक महीने रिवाइंड करो पर चलाते मैंने की दूँ.
Sorry, what's it? What's the way you're saying something? Sorry. Okay, so yeah, I'll just go ahead. So the map there shows the county-based EMS incident rate per 100,000 Arizona residents. So this is like all the incidents like 911, EF, interfacility transports, medical transports. So this graph kind of shows you the distribution of EMS incidents throughout the whole state. So the color that reflects the volume, and the darker color being the highest, and the lighter gray color being the the lowest incident rate. So you can see the La Paz County has the highest incident rate compared to all other counties, and the lowest is the Greenlee. And we also talk about the time intervals in our report, like the response time, scene time, and the transport time. So this here is just a kind of snapshot for the whole state, like average. The median time intervals for all the ground 911 incidents. And Dr. Bell, if you can go down. So here, in the report, like as we did the past years, we didn't look at the top 5 or the top 10 impressions. We took a few impressions, the categories of interest, and tried to describe those incidents, the prevalence and the mortality in them. So, of all the impressions that we considered, injury were the highest, 18.8% incidents. Substance abuse was almost 6%, like 5% of all the EMS incidents. Psychiatric disorders was like 3%. Seizures were almost 3%, and opioids were 2.65, like 3% of the incidents. And the next is like we also discuss about the mortality in each of the impression category. So the cardiac arrest has the highest mortality, like it's almost 58%. The next is STEMI, like it's 7% of mortality in the whatever STEMI incidents we had. Opioid also had 5.3%, stroke almost 4%, and diabetes also 2%. So this is just a kind of snapshot, and the further graphs below will kind of describe you these data in the detail. So sorry, Dr. Bradley, can you go to the next page? I won't go over all the graphs in detail. So basically, this graph talks about the various dispositions we have in our system. And for 2020, almost 60% of the incidents were treated and transported, or 14% were treated and transferred. And this table kind of gives you a breakdown of the different patient dispositions. If you go to the next table, this is kind of the breakdown of Ems response type. So basically, we included only 3: 911, interfacility transports, and medical transports, because those are the main 3, and all others were grouped into other category. So as you can see, the 911 response was 80% of all the EMS incidents, followed by medical transports, which is 12%, and interfacility transports occupied an 8% of the all EMS incidents. Yeah, so this page kind of gives you a distribution between the ground and air agencies. So here we just wanted to see what EMS response type for ground and air. So for the ground, you can see then 80%, 82, like 81% of the incidents were 911 responses. But in contrast to the air, where 82, almost 83% were interfacility transports. So this just gives you a distribution between air and ground agencies. The next page is kind of a summary by month, day, and hour of the day. So the first graph gives you a distribution by month, and here again the color coding. The darker color means higher number of incidents, and the lighter means a lower number of incidents. So as you can see, like during our lockdown period, or when we had, you can see April month, because I think we had almost during the middle of March we had our first lockdown, right? So you can see a decrease in April, May, and those, and again we had like a second wave during August and September, where we had so you can see a decrease there, and again the incidents increased. And the second graph here talks about the EMS incidents by hour of the day. So we just wanted to see what were the peak hours for the EMS agencies. So again, the color here, the darker color represents a higher number, the lighter color represents a smaller number. So you can say that around 8 a.m. to 8 p.m. Those were the peak hours for the EMS agencies. And the next graph is almost, it's again the same thing, but here we again do the hour of the day and the day of the week. So we just wanted to see what were the busiest days of the week. Like here, again, you can see the 8 a.m. to 8 p.m. at the peak hours, but the weekdays more, and the weekends less. So yeah. The next graph here, I just wanted to highlight, talk something about this graph. So this graph basically compares the EMS incident percent and the population percent. So the red color being the EMS incident percent, and the gray color being the population percent. So 0 to between 0 to 45 ages, of 55 age group, you can see population percent is more than the EMS incident percent. But after like 55 to 85, the EMS incident percent is more than the population percent. So basically, this is the age group that mostly uses 911 agencies. So next graph, it's just the kind of by EMS incident rate per 100,000 Arizona residents by age. Here again, the graph talks about the incident rate, the darker color being the highest and the lighter color being the the lowest rate. Greater than or equal to 85 years is the age group that has the highest incident rate. Next graph next page, so this kind of gives you a distribution by gender. So the female and male almost had an equal distribution. There wasn't a much difference gender wise between the EMS incidents. Here, the county, we try to give you the picture of only the 911 incidents here based on the, divided by county. So the La Paz has the highest incident rate compared to all other counties, and the Greenlee has the lowest EMS 911 EMS incident rate compared to another one. So the next graph gives you another kind of distribution between counties, urban and rural. So we kind of divided all the counties into urban and rural. So rural has more incident rate compared to the urban counties. Here, next graph is another kind of distribution between the region. Like in the EMS, we use central office, the EMS agency address to divide the county into based on the region. So this page kind of talks about the EMS distribution by region, and it gives you different like distribution by age, distribution by gender. So yeah. So this graph here, treated and transported incidents, we get this data from the hospital discharge data. So we match the EMS and the hospital discharge data, and then we get the discharge information from there. So Dr. Bradley, if you can just go down and highlight, I just want to say that percentage of, yeah, so 94% of the like the EMS incidents that are qualified, we were able to successfully match 94% of the incidents with the hospital discharge data. And from that we kind of got this information like how many were discharged from ED and how many were admitted as an inpatient. And from those who are discharged to ED, like how many were dead, how many were discharged to other nursing facilities like a SNF or an assisted living facility, and that kind of information. So this graph kind of talks about that, like who were discharged from ET, around 1.5% were dead, but who were admitted to as an inpatient, like the mortality percentage is around 6.3%. And here again, like yeah, the next graph is basically like, now here the same information we try to do it for interfacility transports. So here the next 3 or 4 pages talk about the distribution of the interfacility transports. So the first graph here again, like we talk about the monthly distribution. So you can kind of see an average, and again the color reflects the volume, the low color being the low volume, and the the darker color being the high volume. The next graph gives you a picture by age, interfacility transports by age. So you can kind of see here, like the interfacility transports were more in the age group 55 to 75. So that's the age group where, the mostly utilize the interfacility transport. So 15.6 and 14.9%. So, almost 30% of, data is usage there for the interfacility transports. Next, again, the distribution by county. Here we have by county and as well as by urban and rural. For interfacility transports, Navajo County has the highest incident interfacility transport rate compared to others, and the lowest is the Pinal County. If you go by urban and rural distribution, you can see that. Sorry. Yeah, if you go by the urban and rural distribution, you can see that the rural has more interfacility transport rate compared to the urban counties. The next graph here kind of talks about the overall mortality. Again, we get this information, on-scene mortality is EMS data, but in hospital mortalities, we get the data from hospital discharge database. So this graph kind of shows you the comparison of in-hospital mortality versus on-scene mortality. I think you can see they almost have the same percentage of mortality rate. There is much difference between those two. Yeah, the age groups 55 and had more of them. Now again, this graph, as I mentioned, in the introduction, so we look only at certain impression categories and not everything. So we try to give you a prevalence of all these incidents. So I think yeah, so injury was more because it has like 18% of the data. Next was substance abuse. So I kind of already went through it during the introduction. If you have any questions, I can further answer this, but yeah, pretty much about this graph. So we can go to the next one. Yeah, so this is a mortality percentage, again, like within the each impression category of interest. So yeah, the cardiac arrest had the highest mortality rate compared to any other thing. Next was STEMI, like almost 7% of, mortality rate compared to, things. So here, this year we added a few graphs for response times here. So this page has like three ways to describe the median time intervals. So we did a statewide, we did by urbanicity, and we did by region. And this, it also mentions on how we calculated the response time. So this is a median response time. So when you compare the urbanicity and the rural, so all the response times are almost kind of similar. Again, by excluded data that is missing or that is greater than 120 minutes. And if you go by EMS region, yeah, so again, you can see by central, northern, southeastern, and western. So you can see the kind of distribution by different EMS regions here. And this is for 911 incidents. And the next page gives you the same kind of distribution for interfacility transport. So it gives you a median time by different, by urbanicity and by EMS region. And the next page here, we kind of talk about the Arizona EMCT workforce trends. So this table gives you a kind of a distribution of from the year 2017 to 2020. So this will give you the number of active EMC certifications we have right now, how many new certifications have been completed, the number of students we have like in each year, and the number of paramedic students, and the pass rate, the EMT pass rate and the paramedic pass rate, and the comparisons between national and state. So this table kind of gives you a EMCT trend. And the next page here, again, like EMCT workforce trends, we just wanted to give you demographics, like only for this year, like what is the age range? The minimum age range is 18 and the maximum is 87 years. The median age is 40, and the gender, like almost 84% of, EMCT workforce were male, and 17% were female. So yeah, that table kind of gives you that information. And the last one we have here is like we try to overlay the COVID-19 incidents with the EMS, incidents, and just to see the comparison between those two. And this is by day. So, and here, so you can see like during our, when the stay-at-home order had come and during the first lockdown, you can obviously see the decrease. I mean, this is an average line. So you can see this decrease in the EMS incidents during our first lockdown. And then again, as the COVID cases increased, we will have more, more increase in the EMS incidents. So this kind, and again, during the second time also, we didn't see as a decrease as we saw during the first time, but still they were, not above the average line. Most of the incidents were below the average line. And again, like as the COVID started increasing again, we had more EMS incidents. So this kind of, gives you a comparison between COVID and EMS incidents. And I think that's the last graph we had. If you have any questions, I would be happy to answer them. And I saw a question in the chat, like this is still a draft version. So after it's available, like it's approved, we will put it on the public website for use.
This is Rebecca. I don't have a question. I would just like to commend Vatsal and all of the data team. This is an excellent report. It's one of the best I've seen yet in the years we've been doing this. Well done and excited. Can't wait to get my hands on a hard copy. Thank you.
Thank you, Rebecca, and thank you, Sri, for that wonderful report. Very good description of some of the trends we've seen. We hope to have a finalized version. I'm optimistic in saying within the month. We will certainly notify everyone. It will get posted on the website, but we can also send out a Gov delivery communication once it's ready for publication, so everyone is aware as well. Any other questions regarding some of the data trends for Sri or Vatsal? All right, hearing none. Any agenda items that would like to be added or considered for the next meeting? All right, next is call to the public. Next, summary of current events. These are on the agendas as links for the upcoming conferences. Again, I'm sure everyone knows, just plan on being hybrid or virtual, and we'll be flexible and continue to do so. Our next meeting is January 20th, 2022 at 10:30 a.m. Again, location and format to be determined. We always do have a virtual format. We'll see if we can continue in person. And can I get a motion to adjourn?
Motion to adjourn, Vince Martinez.
Thanks, Vince. In a second.
Second.
All right. Thanks, Roy. All right. Meeting is adjourned at 10:39. Thank you very much, everyone.
Thank you.
Thanks, Gail.
Take care.